Good afternoon, ladies and gentlemen, and welcome to the Cervical and Thoracic Spine Disorders Evidence-Based Treatment webinar. This webinar focuses on signs and symptoms, as well as evidence-based testing and treatment of common cervical and thoracic spine disorders. Today's program is being recorded. There is 1 hour of CME and MOC credit for this program. You received a verification form with today's instructions, or you can follow the link that was in the instructions. No certificates will be sent to you, but your transcript of this and other ACOEM educational programs can be viewed and printed from the ACOEM website. Members and non-members can both view their transcript directly from the website. Today's program consists of approximately 50 minutes of lecture with questions at the end. We'll address questions as time permits, and as in the past, recommend that you submit your questions early for consideration. We are only accepting questions electronically, and on the screen you can see how to open the question box in order to submit your questions. This was also included in the PDF file of your handouts you received with the instructions. This educational activities presenter and planners have indicated they have no disclosures to be made. So at this time, it's my pleasure to introduce our presenter for today, Dr. Jeffrey Harris. Dr. Harris, you may begin.
Thanks, Sandy. Good morning. So we're going to talk today about neck and upper back disorders. This is listed as the revised second edition. As far as I know, it's now pretty much the same information in the third edition. This was a transitional improvement. So the first thing we're going to do, similar to what we did last week with the hip disorders, and as we're going to do next week in the shoulder disorders, is to go through the mechanisms of how one might get one of these problems, both illnesses and injuries. And note that a lot of this is not occupational, so when you're called on to decide whether it's work-related or not, it's good to know the alternative causations to the extent we know them. So if there's a direct blow to the head or neck, or abnormal flexion, extension, or rotational force, and it has to be reasonably significant as opposed to, oh, I turned my head and my neck hurt, that can result in real cervical strain, which is pulling apart the muscle fibers, but short of a tear. In the case of direct trauma, you can get radiculopathy, particularly if there's pre-existing foraminal stenosis. And post-laminectomy syndrome, as in the low back, is a complication of surgery. We're not actually sure what post-laminectomy syndrome is. We used to think it was scarring and adhesions, but it turns out that it can happen without grossly positive gadolinium MRIs. So in terms of illnesses now, and the distinction is that there's no acute trauma, as you know, for the definition of injury in workers' comp. The radiculopathy and spinal stenosis happen whether or not you work at all, and so they appear to be age and heredity related, and those two interact because obviously not everybody who gets older ends up with either one of these things. And that's pretty much the spectrum of disorders. There are not a whole lot of different ones here any more than there are in the lumbar spine. So let's go through how we diagnose these different entities. Cervical radiculopathy has to result in specific dermatomal sensory or motor changes in a complaint by the patient. And then with a specific neurologic exam, again, you should be able to map the dermatomes. Large areas of numbness or pain or whatever typically are unlikely to be radiculopathy because you'd have to get several roots at the same time. On the other hand, spinal stenosis, which can compress the cord, can result in neck, shoulder, and posterior arm pain and weakness of the shoulder girdle and upper arms. So it can be bilateral. Radiculopathy typically is not. And you can have long track signs, meaning bowel and bladder disorders and so on, dysfunction rather, not your typical diarrhea and constipation, but this is control of bowels and bladder. And sexual dysfunction, because, again, the whole cord at the cervical level is being compressed. And not all the time either. A lot of this is positional, so typically it's worse with extension of the neck. Cervical strain results in complaints of neck pain or difficult or reduced range of motion, and pretty much all you're going to see is reduced range of motion. So as we know, a good physical exam of any of these complaints includes a neurologic exam of the upper extremities, and that would be negative in this case. There are a fair number of people who wake up and their neck suddenly won't move, and we don't exactly know what that is, but it's not really a service to call it a strain unless there's an inciting event, like whiplash several days prior. Regional neck pain is diffuse pain, and you really don't see anything on physical. The distinction between this one and cervical strain are a little hard to make, particularly if they say, well, I woke up and my neck wouldn't move, and they do have restricted range of motion, but you don't have a mechanism. That's more likely to be regional neck pain. In post-laminectomy syndrome, you will see sensory changes or pain in the level of the surgery. Radicular signs may or may not be there. They should be, but excuse me, there are instances in which you can have a positive MRI and no motor signs, but typically something is going on in the sensory area. So to summarize this, and this is a nice handy pocket guide. Some people I know have actually put it up on the walls of the exam room. Now that's controversial because then it helps patients figure out what's going on or not. Theoretically, they could memorize this if they wanted to be devious, but I think it's a trade-off you have to figure out. Anyway, so
Dr. Harris, there's been a request just to speak just a little louder.
Oh, okay. Sorry. Is that better?
That's better. Thank you.
Let me see if I can turn this up too. That doesn't look like it's easy to do on this phone. I'll just move the microphone. So again, these are the symptoms that the patient will tell you about areas of pain or numbness for cervical radiculopathy. And the signs, interestingly enough, aren't exactly in the same distribution. There's a great book, I think it's back from the 70s, by Stanley Hoppenfeld called Orthopedic Neurology, which goes into the distributions of various and sundry radiculopathies and compression neuropathies in great detail with really terrific pictures. It's cited as a reference in the guideline, but if anybody's really interested about all this, that's still the definitive standard in terms of mapping this out. So you can read this. I don't know that I need to, but there are these distributions, particularly C6, 7, and 8, are different than what you'll see in carpal tunnel or other compression neuropathies at the wrist. So you can use this to distinguish that. And you'll again notice they don't exactly map to the subjective complaints. And by the way, the most common, it's sort of like in the lumbar spine. There's an area that seems to be anatomically weak, so that there's commonly more radiculopathy in that area. It's L4, 5, and S1 in the low back, and the analogy here is C5, 6, and 7. So that's where the vast majority of the problems are, which is good because the upper cervical dermatomes include innervation of breathing and things like that wouldn't be really good to get fouled up. So what's recommended for testing, you can see here, and essentially this is the same as the low back in that it is not recommended by pretty much anybody to be doing x-rays on acute neck pain or radiculopathy because you're not going to see much in all likelihood. And the patients don't need the radiation, and the expense is unnecessary. If there are red flags, primarily having to do with trauma to the neck, fevers that shouldn't be there, IV drug use, long track signs, cancer history, there may be other things in the red flag list, but if somebody presents with acute neck pain that just suddenly came on and one of these other historical or vital sign problems exists, then it's okay to x-ray because you're looking for something specific, like a fracture or bone erosion from a tumor or osteomyelitis or something like that. And that's not an evidence-based recommendation. There's not a ton of research on that on the cervical spine. There's some in the lumbar spine. And there's also a consensus recommendation that it's okay to x-ray if it's subacute, which is usually defined as more than 4 to 6 weeks, and the patient is not improving. Now, the recovery curve in general for cervical problems is about the same as the lumbar area, which means that by 4 to 6 weeks, 90% of them should be better. So you've really coned down on the number of patients you're dealing with. And again, there's a chronic recommendation that x-rays are okay in chronic neck pain. And this gets close to a fishing expedition because we're not really sure what we're looking for. But if you're going to refer them to an orthopedist, they're probably going to ask you for an x-ray. And it would be embarrassing to miss something like significant foraminal stenosis, which, by the way, is not work-related, but can certainly cause problems. If you suspect neck instability and you are expecting to recommend surgery and they're willing to entertain surgery for spondylolisthesis, which again is not work-related but clearly a problem, flexion extension views are recommended again by consensus. So in the data that we've looked at in California, it's a little bit old, but it looks like 70 to 80% of people with any neck pain get an x-ray, and that clearly is not yielding any useful well, not any, but not yielding a lot of information that's useful because most of those films are acute and nothing is found. So here's a list of the red flags, and there actually is C evidence, which means that it's present but not wonderful, about using MRIs in this case for red flags because you need to find the cause of the acute process if there's one there. And remember, a red flag is not a diagnosis. It's a historical piece of information or a sign or symptom that leads you to believe that there's a problem that is beyond an occupational focus or needs immediate specialist referral. So with progressive neurological deficits, something is progressing, either a root or a cord, and most likely needs some intervention. We talked about history of neoplasia. This would be primarily breast and prostate, I believe, and possibly lung, things that metastasize to bone. Atypical presentations, including multiple neurological abnormalities across nerve roots. So again, that's not garden variety radiculopathy. Fever with severe neck pain, meningitis clearly could be a consideration here. If they're an IV drug user or even diabetics, they're at increased risk for this. In the cases of people who are already wheelchair bound and may have urinary compromise, that's a pretty common cause of this sort of thing, although the incidence of urosepsis is not that high in the first place. But if it happens, then you need to look for this. And signs or symptoms of myelopathy. Now, that's misunderstood a lot. This doesn't mean nerve root compression. A lot of stuff gets miscoded. Myelopathy means cord compression. So we're talking about long track signs again. In the subacute or chronic case, which means subacute 4 to 6 weeks and chronic is more than 3 months, dermatomal and myotomal signs, so skin and muscle in the anatomical distribution that are not getting better, and the patient and the physician are considering either an epidural or surgical procedure, so that there is a consideration of actually doing something with this. And the patient agrees as well, then the MRI is useful to figure out where to intervene, if in fact there's a place to do it. If there's significant trauma with no improvement, then clearly one needs to localize whatever lesions are there. And previous neck surgery with increasing neurological signs or symptoms also justifies an MRI. This is referring primarily to post-laminectomy syndrome. What is not recommended for MRIs are for acute radiculopathy. Why? Because you're not going to do anything about it, and most of those get better by themselves. So the study is interesting, but it's not guiding any action. Repeated studies without deterioration does not make any sense. I've seen this a lot. It's just kind of, well, let's see if anything changed. Well, depending on the diagnosis, which statistically is things like nonspecific pain, if there's no change in the physical exam, this is not particularly useful. Chronic nonspecific, and that's a C recommendation, by the way, and again, C recommendation for chronic nonspecific pain. The exam and the history are not pointing to any specific dermatome, so it's unlikely you're going to find anything remediable. What you might find is remember the rule of decades. If you have a 50-year-old patient, 50% of them are going to have some abnormality on their MRI, which will tempt people to intervene, but it doesn't correlate with signs and symptoms, and so it's probably not going to fix the problem and may make the patient worse. Flexion extension MRIs are not recommended, primarily because they don't yield a lot of useful information and their resolution isn't very good. And the same story with weight-bearing MRIs. Whiplash without neurological signs kind of fits in the same box as a lot of these other things. Whiplash is muscle strain, essentially, and that's not amenable to interventions. And open MRIs are not recommended. This is a consensus decision, and I believe it's because the resolution isn't good enough. On the other hand, if you have somebody who's morbidly obese or claustrophobic, I'm not sure you have a lot of alternative. That's me talking, not the guideline. Discography in the cervical spine is not recommended as well. It's not recommended in the lumbar spine, as you know. The reason is that it has not been borne out to correlate with pain problems or radicular situations. And the other problem with it in the neck particularly, but it's also true elsewhere, is that you can damage normal discs by injecting things into them, and so it's probably not a good idea. And as correlates, MRI discography and CT discography are not recommended either. So to summarize, plain films are recommended for red flags, and it's to find anatomical defects you're going to do something about. Bone scans are recommended after 7 to 10 days for infections, tumors, or occult fractures for the same reason. MRI, you can read the rest of this, but basically you're looking for defects that will guide surgery. Activity modification we should talk about briefly. Similar to the low back, there is pretty good evidence that bed rest and immobilization are not a good idea. In particular, you can get cervical muscle atrophy fairly quickly with acute, if you get people to go to bed or put a collar on them. Collars in particular can sort of become addictive, and then their muscles get weak, and then you're in trouble. By consensus, the panel was not recommending rest, in other words, don't do anything, for subacute and chronic cervicothoracic pain, radicular syndromes, and stable fractures. And that, I think, came from the orthopedic panel members. In unstable fractures, clearly immobilization of various sorts recommended. So the activity modifications that are recommended include limitations on lifting for nonspecific neck pain and adjusting the workstation so that the neck stays in neutral. Now, we're going to get to physical activity suggestions later, so this doesn't mean don't move at all. It just means have things in relative neutral. And that's also true for radicular symptoms. So what do we do about treating all this stuff? Well, in the area of education, there's a panel recommendation by consensus that select patients, not necessarily defined, but I'm sure you know who they are, should be taught about what to do with these syndromes, how to rehabilitate themselves, and where they're coming from. There isn't apparently any evidence that education for prevention works, and the panel didn't make a recommendation one way or the other. Education as the sole treatment is not recommended, and I think where we're going with this is that activity is almost always recommended. So what about pharmacologic therapy? Well, NSAIDs are interesting because there are some research issues with them in a lot of areas. When they looked for the evidence, they found 5 RCTs, but only 270 patients, and all of them pooled in the recent review, which I believe was a Cochrane review. That's not a lot of people for statistical power, and none of the trials were placebo-controlled. They were these head-to-head comparisons with other interventions, so it doesn't really tell you what happens if you didn't use anything. The results were all similar for nonspecific pain. In other words, manipulation, acupuncture, and everything else they compared it to, including Tylenol, seemed to work about the same. The evidence wasn't really clear for radicular pain syndromes. There are basically no head-to-head trials among the different NSAIDs, and there's no strong evidence for dosing patterns. What this refers to is the relatively common practice of using supraphysiologic doses for acute strains. They seem to work clinically, but nobody's ever done a decent study to prove that, and there are increased incidences of side effects, such as gastric problems, if you use long-term high-dose NSAIDs. And unfortunately, there are no quality studies of acetaminophen in adult populations for neck pain either. Paracetamol is kind of a chemical congener of this stuff that's used in Europe, and there are trials for that. In acute, subacute, and chronic neck pain, what is recommended, well, the point is that there's a low side effects profile in a healthy working population. So NSAIDs are recommended, in any of them apparently. There's some information that scheduled dosing as opposed to intermittent dosing is better, and I think a lot of us have observed that clinically. Somebody comes in, says they're not getting better, and it turns out they're taking anti-inflammatories sporadically and give up after a couple of doses. It tends to work better on a scheduled basis. With known cardiovascular disease or multiple cardiovascular risk factors, the panel is recommending aspirin or Tylenol, and that's actually based on research in various other parts of the body, but it's really sort of irrelevant because we're dealing with cardiac stuff here. And counseling on the risks and benefits of various pain medications is clearly indicated. If somebody has increased bleeding risk, and this does not include people on warfarin who should not be taking NSAIDs in the first place, proton pump inhibitors do have A-level evidence to reduce bleeding risk. Sucralfate B-level and H2 blockers like Pepsid C-level evidence. NSAIDs are recommended post-op, and it appears there's some data in other body parts that they're pretty effective in reducing the use of other medications. For radiculopathy, again, scheduled dose for acute problems and PRN otherwise. Tylenol, same story, particularly when NSAIDs are contraindicated or they're cardiac risk factors. Topical preparations, capsaicin, which is the hot pepper extract that has anti-inflammatory properties, is recommended not on the basis of research, but a consensus recommendation. There's no recommendation on various other magical creams and ointments that people are putting together because there's no data. Vitamins are not recommended in the absence of vitamin deficiency. Evidently, a lot of panel members are seeing people using megavitamins, and it evidently doesn't do any good. at least empirically. There's no research. What about muscle relaxants? Because people like these. They're recommended for moderate to severe acute cervicothoracic pain not controlled by NSAIDs, primarily recommended for use at night only because they have a sedative effect, and be careful with machinery. If people have a history of depression or personality disorders, they can get in trouble with these things. And we've seen substance abusers who you can get high under certain circumstances with cyclobenzaprine, so they suddenly start using a bunch of those. It looks like a tricyclic antidepressant, but apparently has a mood elevator effect, and has the mood elevator effect. Diazepam, which unfortunately is still in pretty hefty use, particularly in emergency rooms, is not recommended. It has a long half-life, a higher incidence of side effects, and it's addictive. So the panel was not recommending that. And mild to moderate acute pain, the harms outweigh the benefits for muscle relaxers. For post-op pain, these things are recommended acutely if there's a muscular component to the post-op pain, and obviously keep in mind all of the things we just talked about. The problem with doing studies on this stuff is that it has obvious CNS effects. People know whether they're taking it or not. What about antidepressants? Well, there's no really good evidence that tricyclics and SNRIs work on acute or subacute pain, so they weren't recommended. They are recommended for chronic cervicothoracic pain, similar to the situation in low back, if there's a treatment failure with everything else particularly being NSAIDs and exercise. They're particularly helpful if pain is causing sleep disruption. And what happens particularly with the TCAs is escalating the dose. Just a nortriptyline starter pack often won't work, and you have to raise it. But you have to keep your eye on adverse effects such as urinary retention and some other problems. SSRIs are not recommended because the evidence of effectiveness is limited, and there's a strong, in the neck and the upper back, there's strong evidence in the low back that they actually don't work and may even be harmful, so that the panel extrapolated that as well. So TCAs and SNRIs are recommended for chronic cervicothoracic radicular syndromes as well. This looks very similar to the last slide. And again, SSRIs, I guess what they're saying here is there's limited evidence of effectiveness, but it doesn't work in low back pain, so use them with caution, if at all. Just as a help, because a lot of us see the generic name in our formularies and then don't remember what it was we were calling it before. I put together this table of generic and brand names. So you can see the NRIs are Cymbalta and Effexor. SSRIs are the usual suspects on the right. And there's a whole variety of tricyclics. The one that usually gets used is nortriptyline. Trazodone is good as an augmenter, particularly with sleep disturbances. Anti-epileptic drugs, topiramate is recommended as a consensus recommendation. Limited use, fourth or fifth line agent if nothing else is working, and it doesn't work on neuropathic pain as far as if there's any evidence. I'm actually thinking that there's research on topiramate in neuropathic pain in other parts of the body, and it's probably an extrapolation. Tegretol, carbamazepine is recommended, again, way down the line as a fourth or fifth agent with a failure of exercise NSAIDs, and in this case, manipulation. Part of the reason for that is that Tegretol has some nasty side effects, including blood dyscrasias and not seizures, but undiagnosed fevers and skin lesions. And there's not a lot of evidence of effectiveness in this area, so I'd be careful with it. Gabapentin and pregabalin, which is the precursor of gabapentin, and marketed vigorously by the manufacturer, but there really is no difference except patent protection. The only thing it's really recommended for is perioperative pain to reduce the need for opioids, and that's based on empirical observations, there's a problem with these drugs, which is that a lot of the research was tampered with, and it's really highly suspect at this point. It's not recommended for chronic non-neuropathic pain, and there's no recommendation for chronic radicular pain. So the cryptic note at the bottom basically was that there have been a number of successful lawsuits now that the manufacturers had changed the cohorts after the studies started, all selectively reported the data and so on, and it just really didn't support use of these things in these instances. Colchicine and thiocolchicide, which is related, are not recommended. They do have some fairly nasty side effects, and there's no evidence whatsoever that intravenous or PO use of these drugs help any of the disorders in this list, although they were commonly used. Complementary and alternative medicine preparations are not recommended. Again, this is consensus. It's primarily due to the fact there's very little, if any, data on it. And there's this laundry list there of all sorts of things. Willow bark actually contains NSAIDs, but apparently doesn't work in this particular instance. And the rest of this stuff, it's not even clear pharmacologically why it would make sense. You do need to ask your patients whether they've been using all those things, because a lot of them, at least where I live, will do all manner of things, including acupuncture, manipulation, herbal medicines, naturopathy, and then when it doesn't work, they come and see us. So it depends on which community you're in, I think. Glucocorticoids are not recommended, and I believe this means, it means PO. Excuse me. Unfortunately, there's no quality evidence of effectiveness, and there's quality evidence of ineffectiveness for low back pain. There's going to be controversy about this because people are saying, well, I got to do something, and let's try this, and a lot of physical medicine folks try it, but the data simply isn't there. People will sometimes get better because the steroids have a euphoriant effect. Now, they are recommended if you have acute severe radicular pain. So here we have a nerve root that, for whatever reason, has become edematous, and if you do MRIs, you'll see that. And particularly if they're trying to go through a foramen which is narrowed, the edema, it's sort of a self-perpetuating bad cycle. And with the assumption that oral steroids will reach a high enough dose and reach the site of action, then it makes sense. The data's not there, but it's a panel recommendation. And there are a few interesting studies which are very small in which IV glucocorticoids were used in the emergency room for whiplash-related cervicothoracic pain. And what happens is that if you give them in the first 8 hours, it's usually a methylprednisolone infusion, or bolus, followed by an infusion. And the grades here refer to grades of whiplash, not grades of evidence. What happens is people get better a lot faster. But again, keep in mind this is C-level evidence in a small cohort and hasn't necessarily been replicated yet. And we're not going to see that situation, I don't think, because these people go straight to the ER, and that's who treats them, unless you all are working in the ER as well. Now, those of you that have heard some of these other seminars probably have seen this slide. But the issues with using opioids in most musculoskeletal problems, we're not talking about fractures here, is that they have a low therapeutic efficacy for muscular problems and musculoskeletal problems that are not traumatic with an anatomical defect. There's a wide therapeutic range, and so that means you may have to titrate the dosage, and people have different effects of these things. The RCTs that have been done are done on combinations of opioids, which, if you were on the call for the initial lecture, combinations in trials are hard to keep track of because you're trying to sort out several things you're doing at once, and it's very difficult to do that. It's not a good research design. There are significant side effects, including somnolence, dizziness, tolerance, dependence, and addiction. And that list is actually longer than one slide because it includes cardiac and GI effects and significant mental clouding in a lot of people or judgment problems. Among opioid users, there is a very high prevalence of either aberrant use patterns or dependence. And the problem is that about 50% of the people tolerate opioids, so they just quit using them. They don't like what happens. And you have coned down on the people who, for whatever their reason, are using them, whether it's for dependence, abuse, very, very high level of concomitant psychiatric disorders. And so you just have to be really careful with this. And to me, the issue is that they don't actually work that well, specifically for pain, at least in the studies that have been done. So the recommendations are, for acute use, be judicious with it, only for severe pain, and the lowest effective dose. It's a C recommendation. Not recommended for all pain. And again, here we have select, which is not defined, but it's for treatment failures, and tie it very closely to functional improvement. We rarely see people doing this, but I'd strongly recommend it. You need to bring the patient back in frequently and get a very detailed history of whether their function has improved, find out if they're going back to work for more hours and so on. And if they're not, then you should really stop it because it's not benefiting the patient. Again, post-op, same sort of caveats. And those last two are consensus. What about passive physical methods? TENS is not recommended. I'm going to speed up here a little bit because you can read it faster than I can talk. TENS is not recommended because there's no proof it works. For acute and subacute pain, it may be an adjunct in chronic pain with other therapies, not by itself. And the idea is to reach functional goals and reduce medication. So again, you've got to be watching the patient closely. There's C-level evidence traction is ineffective. Cold is recommended primarily because it's cheap and it's a consensus recommendation. It's not recommended to be done over and over again in people's offices or using these very expensive high-tech devices because there's no qualitative or quantitative difference in what happens. He has C-level evidence, self-application. There's no reason. There's a criterion about whether you need a skilled health practitioner for these things, and you clearly don't. There's no recommendation for neuroreflexology. There's some evidence on this for the low back. It's primarily done in Spain in one center, and there's no evidence for the neck or the upper back. Infrared is not recommended. There's C-level evidence it doesn't work, diathermy, and no recommendation on infrared, no research. Subcutaneous CO2 insufflation, which kind of floored me that anybody would do this, but there is actually a trial that shows it doesn't work. Issues in research, just so you're aware of what you're looking at. This is about manipulation. There are different kinds. There are a lot of them. They're usually aggregated in the research, and so you don't know exactly what's in the black box. The outcomes in most of this research are unclear. There are no trials in the neck versus placebo or sham manipulation. In head-on comparisons with ultrasound, exercise, and conventional physical therapy, the results are the same, so it's not really clear what's going on here. The trials don't differentiate the results by how long they went on, which doesn't help. And the results are heterogeneous if you do a forest plot, so that you can't, the evidence is not at all clear. This will upset some people, but that's just the way it is, both our review and the Cochrane reviews. And there are some vertebrobasilar effects, cauda equina syndrome, and actually death. They're rare, but they happen, so the question is whether you want to expose your patient to something that could do that. There is B-level evidence, but again, it's kind of mishmash the way I just showed you. Apparently more in the direction of positive than negative in the heterogeneous evidence for manipulation for acute neck pain. They're not distinguishing between manipulation and mobilization because the trials don't either. Recommended B for flares, not recommended for radiculopathy. It doesn't make sense to manipulate an inflamed nerve root. It's recommended for cervicogenic headache, and it's not clear to me that those things are occupational unless somebody got whacked in the head. Manipulation under anesthesia and myofascial release are not recommended. Massage is recommended. There's a Cochrane review that shows that it does have some effect in the chronic situation. Again, it's an adjunct and it's recommended in limited doses only, not ongoing. And mechanical devices for massage are not recommended. Acupuncture is not recommended. This got some people very bent out of shape, but there's no quality evidence on this. There are 5 high-quality trials and 23 moderate-quality trials, but they're all over the place. So you get marked heterogeneity, and you don't really know the answer. There is a little bit better evidence for chronic pain as an adjunct. And where I work, we actually do that, but you have to go through the pain program first. The rest of this stuff really is either no recommendation or not recommended because there's an absence of evidence that it's effective. Sleep position recommended to be comfortable, and no recommendation about magnets or pillows. What about active physical methods? Well, there's a consensus recommendation for aerobic exercise on a graded basis, and for stretching, there's actually a few studies that stretching is effective in chronic neck pain. They did not make a recommendation on exercise for prevention. There's no data, or for yoga. Strengthening and stabilization exercises do have some B-level evidence, but they should be done with aerobic exercise, and if needed, fear avoidance behavior training, which is a form of cognitive behavioral therapy. No recommendation for yoga. Functional restoration is recommended as it is in the rest of the spine on an acute or chronic a subacute or chronic basis. But the problem with this stuff is, again, it's all over the map, and so the protocols and the programs are not at all consistent. Psychological therapy, it's pretty much CBT for fear avoidance. Ergonomics are recommended, but the data is not there. What about invasive procedures? Well, epidurals are recommended as a second or third line option for acute and subacute radiculopathy with failure of other therapies, and unfortunately there's no data to really support this one way or the other. It's a consensus recommendation. Same story with chronic radiculopathy, and that one was extrapolated from the low back. Infusions of steroids are not recommended. This is not the whiplash study. This is something different. Basically, there's essentially no sham-controlled studies. And they don't make any sense in non-radicular pain because there's no edema that you're dealing with. These various and sundry interventions involving injections are not recommended. There's no evidence that they work. Rhizotomies are recommended for chronic pain without radiculopathy if the diagnosis is confirmed by medial branch block, which is sort of circular reasoning, and it's a salvage therapy for failure of other treatments. Now, there's a conflict in the literature. These things don't work in lumbar pain, which kind of doesn't make sense. And there is data that doing them on an acute basis is a bad idea, especially for cervicogenic headache. There are research issues with this too, which we can whiz through, but basically the people in the sham group were more likely to be involved in litigation. There's a high number needed to treat, a higher incidence of adverse effects in the intervention group, and they don't work in lumbar pain, so it's not clear that this research is robust. Dorsal ganglion blocks, there's no recommendation and no research. Surgical procedures. Essentially, discectomy, not fusion, is recommended with C-level evidence for ongoing nerve root compression with clear physical findings and significant pain and limitation after at least 6 weeks, failure of other therapy, and the patient consents. This was extrapolated to cervical radiculopathy, thoracic, which is harder to pick up because it's basically sensory. And peak cages were recommended on a consensus basis only as an adjunct procedure. Discectomy is not recommended in the acute situation unless there's a progressive defect, progressive deficits. And they're not recommended with no radiculopathy because they just don't work. There's no anatomic reason why they would. Percutaneous discectomy, laser, and coblation are not recommended due to lack of evidence. Fusions are recommended, but it's very selective. It's select patients, again, not defined. And typically they also have spondylolisthesis, so that there's a stabilization issue here. And it's recommended at the time of discectomy, consensus only, if you're doing a second discectomy on the same disc, presumably for stabilization. It doesn't work on chronic nonspecific pain. The problem, as you all know, is that if you fuse things, the discs above and below tend to go out, and people end up in worse shape at some point. Pulsed electromagnetic fields are not recommended. There's evidence they don't work. Autologous platelet gel doesn't work either. Disc replacement is recommended for subacute or myelopathy. There is evidence, but it's not hugely robust, and it's not recommended in things that don't involve radiculopathy. Decompression surgery is recommended for stenosis. Fusion isn't recommended unless there's instability. Spondylolisthesis and stenosis, by the way, are pretty much not occupational, so this is sort of an FYI. Vertebroplasty in fractures is strongly not recommended. It doesn't, apparently it's worse than not doing it. And it doesn't seem to work in nonspecific pain. Same story with kyphoplasty. Stimulators are not recommended. The folks who make them got very upset about this, but the data simply doesn't support it. So, how about some CME questions?
And I just want to remind everyone to please submit your questions electronically that you might have for us to address after we go over these 3 CME questions.
Right, and there's a delay apparently, so the sooner you do this, the better. So, if you found sensory loss in the 4th and 5th digits in a hand, what do you suppose could be causing it? Is it ulnar neuropathy? Is it C7 radiculopathy? Is it C8? Is it a double crush syndrome? Is it both ulnar neuropathy and C7? Or is it ulnar neuropathy or C8? What do you all think? Well, there's no way to get feedback. Unfortunately, we're not using the audience meters on this. But the answer, is number 6. You can see loss in the 4th and 5th digits with ulnar neuropathy, and you can also see it in C8 radiculopathy. So it's a bit hard to sort out. What is supported by evidence of effectiveness for neck pain? Traction, discography, IDETs, spinal cord stimulators, prolotherapy, none of the above or all of the above. If you said all of the above, unfortunately, wrong. The answer is 6, none of the above. And, oh, there's the green blob. Okay. And cervical fusion is recommended for chronic nonspecific neck pain, routinely in spinal stenosis, degenerative spondylolisthesis, and select patients with radiculopathy from disc herniation, or 1 and 2, or 3 and 4. And the answer is 6, 3 and 4. So, Sandy, do we have any questions yet?
Yeah, there were a couple questions that were submitted.
Okay. Can I speak up? I hope I have done that.
Yes,
What is
you did.
the specific lifting restriction for neck and neck pain with radicular symptoms? I don't think they actually got to a weight level. There were the 10-pound limit was bandied about. So, but the problem is there's no dose-response research on getting into trouble with different weights. So to some extent, it's patient-specific. I think a lot of people use 5 to 10, but that's about as far as we can go. What is cervical-brachial syndrome, and are there any restrictions for this diagnosis? The diagnosis is not something that was considered in the guideline. I don't know if I should go any farther than that. It tends to get used by chiropractors, and there are some PM&R people who use it. Because it's not in the guideline, we really don't have restrictions for it. So that's the questions we have so far.
That is correct.
Now, why don't we do a couple of cases? And if you have some opinions about this, so let's do a case here. So Catarina Cuello, who's 30 years old, woke with pain in her neck 5 days ago. She hasn't moved it at all because it hurt to move it. The pain is getting worse. Pain is now also moving into the occipital area. She also has mantle-like numbness. If anybody has any comments about any of this, go ahead and fire them off through the question procedure. She's a customer service representative. She's been under a lot of stress. She does not exercise. And as many of my patients, she's seeing us as a last resort because everything else didn't work. On the other hand, she may have legitimately been doing that because when she had this problem before and went to see a doctor, she felt like she was blown off. So on physical examination, she's holding her neck and upper body rigidly. There's mild tenderness to palpation of the trapezius and paracervical muscles. The neurological exam is negative. There are normal vital signs. She's 5'3" and weighs 200. Is there anything anybody would like to know about this in addition? I don't see anything coming in yet. And are there any tests you'd like to do? Does she have a headset for phone use? Good question. And the answer depends on how we set it up, but the answer is no. So she's got her head cocked off to the side.
And there was another question. How does she hold her phone?
Oh, right. Same question, I think. She sort of has her neck cocked off to the side. Yeah, there it goes. I guess there's, I don't know how long that delay is. Good questions.
And
does anybody want
to comment, then isn't it, or then it isn't work-related?
It isn't work-related. And why would that be? So she's got her neck cocked off to the side, and they didn't give her a headset, so I think that actually is sort of an up-in-the-air question. So it turns out she was also physically abused as a kid. She doesn't like her job. One of your colleagues, not you of course, ordered an MRI which showed small central disc bulges. So does that MRI tell you anything? Oh, I see. Somebody says there's no described activity at work that's causative. I guess the question is causative of what? If she's got her neck cocked to the left, something may happen. Clearly it's not radicular, but anyway. What treatment plan? It's amazing to me that a lot of people like this don't get headsets. That just doesn't make sense. But anyway, what treatment plan would you propose? Anybody got any ideas? I don't see anything coming through yet. Let's move down here.
If you want to go ahead and click on that Manage tab, you'll see them come in quicker.
Manage tab. I don't think I've got that one.
No. Okay. We've got a couple of responses here.
Okay. NSAIDs activity modification makes sense to me. So, and maybe heat, because that's recommended. I don't think I have control here, Sandy. My down button's not working, but anyway. So, what would you like to know now? Any other questions about that? So, she comes back in 3 weeks asking for a letter saying she was off work for medical reasons and still needs to be off. She's now reporting burning pain in most of her upper body. She says the pills you gave her didn't work, but her friend's Percocet did, and she needs more, about 6 per day. Does anybody know what you would be thinking about if somebody comes in and asks for a specific opioid and how much they need? Well, that's one of the criteria that the chronic pain guide says watch out for, because people that have knowledge of various opioids and get them and want more, not necessarily are abusing them. It's just a red flag that you need to be paying attention to. However, what do you all think about being off work this long? And what would do you have any ideas about what would you propose now in terms of, drug seeking? Yeah, that's very possible. So somebody got that one. Any proposals for any further treatment at this point? Well, NSAIDs and PT didn't work. I don't know if she's exercising or not, but at this point, she needs to be, in the generic sense, rehabilitated and really start to work on stretching and strengthening exercises, more aerobic exercise, and so on. Whether or not that involves work hardening or work conditioning programs, or at 3 weeks a multidisciplinary program, I think is up in the air, because those things tend to be intensive. But clearly increasing activity would make sense. And the other thing that probably would make sense with her is fear avoidance CBT, because she demonstrated initially she really didn't want to move around. And it's not clear. What we don't know here is what her compliance was with physical therapy and what the physical therapy was. And somebody else got those answers. So thank you very much. But again, this is one of these ones where somebody, maybe it's a PA or your assistant, is talking to these folks a lot. Pardon me. In the old guideline, we had some contact, not necessarily an office visit every week, to find out how they're doing functionally and find out how they're doing with their activity and so on. And if it's not happening, then we've got a problem. And I think, are there any more questions?
No, there's none in the queue.
Okay. So we have about 2 minutes. I guess we should just, excuse me, finish up here. This cough, by the way, is work-related, since I work with a lot of people with URIs. But I'm not on comp. Epidural steroid injections. This is a pre-cert request. For neck pain, it's at 2 weeks, functional status working. There's no neuro exam in the request. And the only thing that was in there was restricted range of motion. Would people authorize this? That's a no, I hope. Epidurals, pain and neck pain in both arms. Neck pain and pain in both arms. Restricted range of motion, normal motor function. Pardon me, they're not working. They're 10 weeks out. Does this make any sense? Answer no from the group, and of course not. Neither one of these makes sense. Request for physical therapy. Neck pain started 2 days ago. We don't know their functional status, and they want to do PT, and they have not specified what it is, 3 times a week for 6 weeks. And the answer, somebody said only the epidurals only made sense if there was evidence of radiculopathy. That's absolutely correct. And the problem with this PT request is that we don't know what they want, and they don't have any physical findings, and it's acute. So at least they didn't tell us what the physical findings are. So that would be a no. So we're out of time, and I want to thank everybody very much for excuse me, for listening and putting up with the cough. And so next week we're going to do shoulder disorders. Same time, same place.
Thank you, Dr. Harris, and everyone for their attendance today. This does conclude today's program.